Welcome everyone to our first episode of the Impressions podcast, proudly brought to you by the Wits Students Physician Society. Through this podcast, we aim to explore the field of internal medicine with exciting guests and cool segments. Today with us, we have our first guest. Very excited to welcome Dr. Juan Jansen van Vuuren, who is the founder of the Physician Society. Hi everyone, and welcome to the Impressions podcast for the first episode with a special guest. I'm Antonia, and I'm the chairperson of the society.
I'm Henry, and I'm vice president of the society.
I'm Charles, and I'm head of tech and YouTube.
And with us, we have our founder of the Physician Society. Welcome, and thank you for joining us. I don't know if you'd like to just give a brief introduction on who you are, where you are, and all that.
Yeah, so thank you so much. It's really exciting. So I'm Jean. I am actually currently working in the UK. I'm just finishing part of my internal medicine training here and then starting my intensive care training in about 2 weeks' time, which is really exciting. And then, yes, I started the society way back when with my wife, Claudia, who unfortunately couldn't be here with us today.
And what initially drew you to internal medicine specifically?
Yeah, so I don't want to sound lame, but probably a bit of House and Scrubs. That was probably what started it off. So when we started our clinical rotations in third year or GEMP 1, I remember working at Barra and we rotated through Ward 20, which I don't know if it is still the internal medicine sort of acute ward. But I saw, and I saw the physicians there, and their breadth of knowledge was just something to aspire to. The way that they were with patients, the way that you can ask them anything, whether they were a rheumatologist, a neurologist, or any of the other ologists, they were just so well in tune with physiology and pathophysiology. And that's probably what started my love for it off, yeah.
Okay, wow, that's very interesting. From what I understand, you're aspiring to be a neurointensivist. Can you please tell us a bit about what that is and what it entails?
Yeah, of course. So in the UK, things are slightly different in terms of the training. And essentially, you have to undergo core training, which is 3 to 4 years of just general internal medicine sorts of things. And then you go into your subspecialty or high specialty training. And initially, my goal was to do intensive care. And I absolutely love intensive care. It brings everything together for me. I remember I still talk about Prof. Richard's Stewart Strong Iron Theory lecture from Renal. I remember that very, very well. And it brings all of that together. Now, why neurointensive care? Well, when I finished my community service in Pietermaritzburg, I started working in the neurology department at a hospital called Gray's Hospital. And I spent about 3 years there. Absolutely loved every minute of it. And I think it combines probably those two loves, the neurology and then, the intensive care bit of it. So in the UK, there are a few tertiary centres that specifically deal with neurointensive care. So it includes both surgical cases, so neurosurgical, post-operative and pre-operative stabilisation, but also neurological intensive care patients requiring post-stroke care, AIDP, that sort of thing. And in fact, I think the thing that clinched it for me was the first day when I walked onto an intensive care unit here, and there was a patient who was a real diagnostic mystery to the intensivist, and they were just about to intubate the patient, and I went and greeted the patient and shook his hand, and as I was shaking his hand, his grip strength got stronger and stronger and stronger. And I said, hold on, are we sure we're dealing with a GBS sort of picture? It ended up that he had something called Lambert-Eaton myasthenic syndrome, and we managed to treat him, avoided intubation. He had his last cup of tea, because that's all he wanted before things went south for him. And unfortunately, he did pass away, but we were able to give him his last wish just by shaking his hand, which is really reassuring.
What advice do you have for medical students interested in pursuing a career in internal medicine?
It's hard work, so you need to be prepared for the hard work. The amount of knowledge that you need to have is so broad, but that's probably the beauty of it. You will be walking the corridors and anybody from any other discipline can walk up to you and say, please, can you give me some advice on this? And you'll have an idea of what to tell them. So the advice that I would give is, don't be afraid of the hard work. It's a tough road and we stumble on the way, and that's absolutely fine. And the whole point of it is not to be perfect on day one, but you can certainly strive to be perfect one day, even if we'll never reach that. It's a continued learning endeavor.
And on top of specializing in internal medicine, you've also published multiple peer-reviewed papers whilst working. Can you walk us through that process and what it was like?
Yeah, of course. So I was a bit of an opportunistic researcher, I think, is probably the word I'd use. So I was working at a hospital, it used to be called Edendale Hospital in Pietermaritzburg. It's now called the Harry Gwala Regional Hospital. And the first time I published was a little case report on a gentleman who had a few sewing needles stuck in his heart. I then got the taste of seeing my name in a journal, and it was really an awesome feeling. So I tried to look for opportunities, and I sought out opportunities to be able to publish. And I think I had a fantastic mentor, Prof. Pillay, who used to work in a diabetes centre at the same hospital, and we worked together on quite a number of papers. But I think it's all about being opportunistic about it. So ask a question and think, how can we answer this question? And it can literally be as simple as, oh, I see we're doing a magnesium on every single patient. I wonder if there's a link between magnesium and HbA1c. Or it might be as simple as, oh, right, I see that we're doing routine ECGs on all of our patients coming through the early assessment unit. I wonder if there's a relationship between the QTC interval and mortality or morbidity at 30 days. So it's all very simple things that you can just look at things that we do every day. It doesn't have to be difficult. And then grab onto somebody who knows, has an idea of what they're doing, so that they can help you through that. Now, for me, research was always a very personal thing. During my time as a medical student and then as an intern as well, I found it a good hobby outside of working those grueling hours that we do.
Okay. So, Doctor, I just have a follow-up question on that. Would you say that medical students applying for their different internship hospitals should consider applying for a hospital where they will have time to do research?
Yeah, I think it's difficult. I think probably more so in the last decade since I was an intern. I think the workload has just gotten more, and the conditions under which you're working has gotten more difficult. I think it's a very difficult balance, and it's a very fine balance that you need to have between your own mental well-being and things outside of medicine, but also you're progressing your career. Now, I was fortunate enough to have registered for my MedSci during internship, and that's actually how I ended up getting my master's during internship.
Okay.
But it doesn't have to be a big center either. Even if you're in a small district hospital, there are loads of research opportunities. And most hospitals have got some sort of link to a tertiary center or a university where you can reach out to and say, look, I'm currently working in the family medicine department of this really small hospital. I'd really like to do some research. And the easiest often is just to do observational studies. And you can just look and go through some notes and go through some files. For example, how many chest X-rays do we do, and do we find nothing? How many how many patients do we admit for pneumonias where their CURB-65 is actually really low? That sort of thing. It's so easy, and the questions can just come as you go along. So it's not that important, I would say. Obviously, if you're working at a very tertiary centre in Johannesburg, for example, you might find it very easy because everybody wants to publish. But at the same time, you may find it difficult because everybody wants to publish, so that everybody wants to have their professor such and such helping them with their studies. Whereas if you're in a smaller facility, people might be a lot more happy or more willing to help you if you show that initiative.
Sorry, I just have one more question on that. Can you please tell us about your master's? How did you get your master's? Where did you do it in?
Yeah, of course. So again, it was very opportunistic. It was in that same diabetes centre, and it was I actually watched I think it was the NEJM that had a small little blurb on psychiatric conditions in patients with metabolic diseases such as diabetes, hypertension. And I wondered, could there be a link between diabetes and diabetes control in the form of HbA1c and something like major depressive disorder, which we know is really particularly common. Now, again, this was during my internship. I then approached the then Dr. Pillay, who's now Prof. Pillay. He gave me the opportunity or the platform to work in his clinic, and we had the opportunity to collect data from his clinic. Now, the main thing that we were looking at was to see, firstly, what was the prevalence of major depressive disorder in patients with type 2 diabetes, and we found that it was really high. It was far higher than we thought it would be, and then we tried to determine whether the severity of the depression, if there's any link with their control of their diabetes in the form of HbA1c, which we then found a linear correlation with the worse the depression is on the PHQ-9 score, the worse their glycemic control is, which makes intuitive sense if you think about the fact that if they might not have they don't have the drive to take their medication every day. And it's because it was an observational study, we couldn't pinpoint causation, but we could look at the correlation. We could definitely say, A correlates with B. Whether A caused B or B caused A, we don't know, and it's certainly very multifactorial. So I took this idea to him and I said, look, I think I want to do my master's. So an MEd Sci, in other universities it's called MSc Med, but at UK then it was MEd Sci, and I started my journey through that. So I did it via publication and through thesis, and it was actually a really good process. It was a steep learning curve because I did my statistics myself, so I didn't have anybody, so I had to teach myself a lot of stats, which was lots of fun. I think I'm very lucky that so Claudia, so she in her BSc, she did stats, and she got, and I'm not even kidding, I think she got 99.9% or something ridiculous, or it might have even been 100% for stats. So if I didn't know what to do, I just said, Claudia, would you mind just helping me?
That's great.
I mean, I remember in my first year when I bunked stats, most of it, which is terrible. So I can't remember anything from first year BSc really. But yeah, so I think if you've got the drive, I think it's definitely possible for you to do that. Because I then registered, I went through the ethics component thereof. And because I've already gone through ethics before, it wasn't that difficult, I came up with a short proposal, which was very much, just I had a blueprint in mind already, and I fell back on that. And I think if I look at the work I did then, I would change so much, because it was a steep learning curve. But it's definitely worthwhile. And I think it does set you apart for when you go on to apply for registrar posts, and especially now in an environment in South Africa, certainly, where the competition ratios are so high for posts that you really need something to set you apart. because at the end of community service, you have got the exact same qualification as everybody else. You've got your MBBCH or MBCHB, and the question is, what else have you got? What else can you bring to the table?
That's definitely some good advice.
Yeah, that's really interesting.
Very
Wow.
good. In the same vein, do you have any tips for medical students or junior doctors who want to get into like academic medicine?
Yes. So this is where you want to latch on like I don't want to say a parasite, but certainly something where there's a symbiotic relationship with a professor somewhere. And the reason I say this is because you will have good contacts. I think that you would have the opportunity to be a part of their research. You can offer your time up and say, look, if you need somebody to do the legwork and data collection and you want me to go and find out, I can carry the papers to your office if you want me to. I think that's probably one of the big ways that you can do that. Now, if you were looking at clinical trials, for example, there are loads of companies, which I know with recent sort of international political shifts may have become a bit more difficult. But for example, large companies like Caprisa or the Wits RHI, that sort of thing, to get your foot in the door there. There are loads of, the benefit of being in the UK, there are loads of opportunities here to become associate principal investigators through the NIHR. And if you look these things up online, you might find that you can do their certificate to get good clinical practice for your GCP certificate, to be able to start off with these trials and research.
And you've spoken now quite a bit about your different publications, your masters, and your case report. Is there any specific publication that is the most personal or has had the biggest professional impact in your life?
Yeah, so I think, so I'll split it into two. So the one is certainly the biggest impact would have been from my master's, so the SAD study, or sugar and diabetes study, sugar and depression study, because that has opened so many doors for me. It's so highly regarded around the world, and certainly here when I applied for specialty training here, it's all very points. You get points for what you've published, and beyond this, it would only be a PhD that would have got me more points. So I think that was probably really good. During just prior to moving to the UK, I was working on a sort of a scoping review article. So that was the last one that I published before leaving South Africa. So I think that's probably one that will always stick with me as being the last one since moving.
Okay. Would you ever fully step into research? As medical students, we are bombarded with that question sometimes. Are you going to stay at the bedside, or are you going to be a researcher one day? What does the future hold for you?
No, I don't think I'd ever be able to step away from patients. I think I genuinely love it. I think it's, to me, now as well, I get to kneel down next to a patient's bedside and, just talk to them and hold their hand and walk them through this. And it's, yes, when you are fully in research, you can make big changes. If you discover a fantastic new drug, that's great, and you will change the lives of millions of people. But I take solace in the fact that I change the lives of a handful of people every day, where I get to just interact with them on a personal basis. So probably not. Although maybe in 20 years I'll be singing a completely different tune.
Yeah.
So you founded the Wits Physician Society in 2013. What inspired you to create the society? What was your initial vision?
So I just enjoyed my internal medicine rotation so much. I used to sit during holidays and sort of just page through Harrison's, thinking one day I might know 1% of what's in this volume. And I thought that the Surgical Society had been doing incredibly well. And I thought, well, I wonder if there's something like that for people who want to be physicians. Because, yeah, it's really cool to be a surgeon. I can't even cut a slice of cake properly. So you wouldn't want me to come near you as a patient with a scalpel. But I thought there should surely be something. And when I looked for it, and perhaps I didn't look very hard, I just couldn't find one in South Africa or indeed on the African continent. And I then said to Claudia, it would be really nice if there was a society one day for people who want to do internal medicine. So she said, okay, I'll do the logo. And I was like, what do you mean you'll do the logo? I wasn't saying I'm going to do it. She's like, no, we're going to do this. And I think that's sort of where it started. I think I wanted to, the main mission was to cultivate this space of, where we can really push people's boundaries and expose them to parts of medicine that they may not be exposed to. When you are stuck working in a small district hospital during your student internship time, you might not be thinking of things like internal medicine because it's really, you're just slogging away. Whereas the idea was to have this environment where we could come together and we can have a chat about what we would like to achieve as doctors if we were going to pursue internal medicine.
Yeah, thank you for taking the step. I think speaking in our position now, it really has benefited us as students having that internal med society on campus. I think the society has grown significantly over the years. And I think for you, I don't know, looking back, how have you seen the society? What are your thoughts? I think from the glimpse you've seen on social media and heard from us.
Oh, it's gone beyond what I thought it could. Honestly, it's incredible. I think it's just, when we started, it was, honestly, we had no idea what we were doing. We made a constitution, and I was like, I don't know what I'm doing with a constitution. And I remember eventually we ended up becoming sort of a sub society of MSc, and I remember going to who's now Prof Muhammad at the Gen, and I went and I said to him, look, as a Department of Internal Medicine, would you support us doing this? And they were very supportive, and I think we were just very fortunate in many ways. I think there was a there was like an expo for medical equipment, and that's where we met somebody from Mediclinic, who then went on to sponsor our first year. And so I think from stumbling through that, now looking at how organized you are as a committee and as a society, and how much you're doing and your outreach over the last 2 weeks, it makes me really happy to see that.
Yeah, we do work very well. Thank you. Thank you for that. I've got a more general question. Can you please tell us, what was Wits Med School like when you were here?
It was incredible for so many different reasons. It was, so to get to medical school was quite the uphill battle for me personally. So, I remember sitting in my first year BSc stats class, the one that I went to, thinking, what, I don't want to be doing this. I want to do medicine. And when I had the opportunity to go into the second year BHSC, I remember going in about 6:30 in the morning to go down to the Anne Andrews lab and look at the physical slides. I don't know if you still have the little slide boxes or if it's all digital now, but I remember that smell of yeah, it was all physical little slides and a little box, and I remember that smell of formaldehyde as you go down there, and
that hasn't left.
Get close to the second floor and it's there.
It's still there. And I then, when I started Gemp 1, I felt very out of my depth, and I felt very out of place. I think I still look back and I think, did I really deserve to be there? When so much throughout your early career says, no, you don't deserve to be here. You're not good enough to be here. And then for you to have that opportunity to step in. And I remember walking in through those doors the first day as a medical student, that overwhelming sense of gratitude, I guess. Also, it was very special for me because only a few months later I met Claudia in Lecture Theatre 2. So that's probably the best part of medical school for me. And it was just an incredible journey. I think I've got the benefit of now seeing how things are done in a different country, and I teach loads of medical students here as well. I think as South African medical students at Wits, I think we are at such an advantage because we had, and you still will, you have the academia behind it. So the people teaching us at Wits were and still are world class. But then you also have the sheer volume of patients that require our help, that as a medical student, you do so much. When I say to medical students here that, in my third year as a medical student, so in GEMP 1, I did a lumbar puncture, they would be like, what? What do you mean you didn't get the neurology registrar to come and do the lumbar puncture? Like, no, this is what we do, so you've got the benefit of the practical experience as well as the academic foundation. So that's something that makes Wits very special and makes the medical school very special. Yes, the expensive cafeteria was also really nice, but I don't even know what I don't even know what the prices are. Is it still olives and plates?
Yes.
Yeah, incredible food. I mean, I remember that really well. So yeah, it was an incredible place. I think the support from faculty was also quite good, and I think we had the benefit of having people that we can go and talk to, and especially as somebody who never knew his roster, it was always really nice to be able to go down and just be like, listen, what am I doing this week? And get a printout of what I was meant to be doing that week.
So you mentioned that sometimes we feel like we don't we have that feeling that we don't belong, kind of like imposter syndrome. With imposter syndrome and rejection in medicine being quite prevalent, what do these moments actually look like, and how do we approach them?
Yeah, so that's such a good question. I did an imposter syndrome talk a few years ago for the UKZN's Doctoral Society, and as somebody who I'm really very hard on myself, and I think we all are, aren't we? To varying degrees. I think I've only ever met one doctor who said, "Oh, imposter syndrome. I don't even know what that is." And I thought to myself, well, that nice, okay, well, fine. I think it's a double-edged sword. I think it's got the potential of being good. I think it makes us want to be better. I think it makes us want to prove to ourselves and other people that we do belong here. We do deserve to be here, and we are good enough. I think it's difficult in the sense that when we then do achieve something, we think that must have been a fluke. I think that must have been a mistake. That they're going to find out that I'm not actually this good, and I still have it to today. When I got the training program here, when I got the email to say, well, congratulations, you've been accepted, I thought to myself, no, this has got to be a scam email or something. Somebody's, there's some sort of fake prince somewhere in Europe trying to take my money. And that feeling doesn't go away. But what we can do is we can use that as motivation and say, okay, fine, I feel like I'm not good enough. So what can I do in this moment that will make me feel good enough? And whether that's going through your list of achievements, like saying, well, look at what I did today. Today I did a lumbar puncture. I used anatomy to take off a pleural effusion. Or today I managed to study this whole week's work. And I think that's what we need to take forward, and that's what we need to take out of it, is that how far we have come, and we might not think that it's good enough. It certainly is good enough.
Really good.
Yeah. And on the topic of that feeling of just challenges, what are some of the biggest challenges that you've had to overcome personally and professionally on your journey to where you are now?
Yeah. So I was 6 months out of medical school, and this is something that I share quite readily. So I was about 6 months out of medical school when I felt a little lump on my neck, and that turned out to be cancer. And I had to have quite a lot of chemo, and then it was actually during my first lot of chemo that I published my first 2 papers. I then subsequently went on and had a number of recurrences, and with each recurrence I felt even more driven to be able to do good, and not just in medicine but in my personal life as well. I think the biggest challenge was about 3 years ago now, when just before I came to the UK, I had to have a transplant to eventually cure my cancer. And that was undoubtedly the biggest challenge, not just because of the process of going through that, but because I have a small little family, and my wife Claudia and our son James, and that was the biggest challenge. But I was able to take so much out of that, and I had the opportunity to bring that experience as a patient into each patient interaction that I have. Now I know that when we are on a ward round, when I see these patients, it's very difficult for you as a patient lying there to be looked down at from the doctors around you. So more often than not, I pull up a chair and I sit next to the patient so we can look each other in the eye. And those small things that we can't teach people. So that was probably the biggest personal obstacle. Because it was 5 months after my transplant that I had my first night shift on the NHS, and that was interesting, to say the least. But I can just reiterate, and I think you can see a picture of my son in the background there. Him and my wife were just the most incredible supporters. And I think the main thing that I learned out of that is that I don't think that everything happens for a reason, but I think that we can give reason to everything that happens. And that's probably my biggest challenge from a personal point of view. Professional point of view, all the rejections to medical school. I applied everywhere, and I was just told, no, not good enough. The rejections to reg posts. Well, first to MO posts after ComServe, then the rejections to reg posts, and again and again and again. And again, I think what I took out of that was probably a ton of perseverance. And for every rejection, I made sure to take something out of it. Again, to say, I am good enough. There are other reasons that I may not know, that I may not realize why I didn't get that post, but I'm still good enough. And we all know how pressured the system in South Africa is, and there are a finite number of posts, and so many doctors vying for that one post. And ultimately, every single failure, I said, well, what am I going to do to be better next time? Am I going to publish another article? Am I going to do another diploma? What am I going to do? And ultimately, I think it taught me to, it just taught me to be a lot more resilient than I thought I could be.
Thank you for sharing that, Doctor. That's really inspiring. So also in this line, when you look back at your career, say in a few years, and all your metrics are stripped away, what kind of doctor do you hope people say you were?
Kind. I think that's what I want to be. Kind and compassionate. You know, you can lose all the letters after your name, and then ultimately that's who you are. And somebody once said to me that, you know, at the same time as we're working on our CV, we're also working on our eulogy. So we are working towards what we are now and what we're achieving today, but we're working towards what people will remember us for. Will they remember you for being that doctor who would walk down the corridor always smiling, greeting anybody, doesn't matter who they are? Or will they think of you as an arrogant individual who just didn't care? So that's what I'm hoping. That's what I'm hoping that people will remember.
That's very inspiring. Thank you.
Thank you, Doctor.
So you've worked both in South Africa and in the UK. What are some of the most notable differences between the two healthcare systems, you'd say?
So I think the systems are very different. Okay, and I think the systems are different for different reasons. I think the volume of patients who require care in South Africa is very high, as it is here, but the resource allocation is completely different. So there's no disparity, or there's no large disparity here between those that can afford a private medical insurance or medical aid and those who can't. Doesn't matter who you are here, you get treated on the NHS. And when you realize that when you lose that disconnect of those are patients, I'll never be in that bed. I'll never be in Ward 20 at Barrow. I'm going to be in Saint such and such's private hospital. There's an immediate disconnect. But once you can see yourself or your family member in that bed, it shouldn't be that way, but for many people, it just immediately changes the way that they treat patients, and I've seen that here. We read and we see all these horrible stories of how people say they were treated in South African public hospitals, and I just wonder if it wouldn't be different if they could see themselves in that bed. I think, again, resource allocation is completely different. For example, I'm currently working in a relatively small, few hundred bedded district hospital, but we've got CT scanners, MRIs, we've got specialists, so cardiologists, rheumatologists, etc. on site, and this is a small hospital. So I don't feel when I'm on the medical registrar I don't feel alone because there's always somebody. Whereas in South Africa, I felt very alone often, especially those long nights after having worked a whole day on the ward, and then you've got another 16 hours left. And after 8 o'clock, often you feel like there's nobody there to talk to. Whereas here, there is always somebody, whether it's the critical care registrar or whoever it may be. I also find that there's a really good system here called, it's like an early warning score, where all patients have their observations or their vital signs put it onto iPads. So everybody's got their iPad. And once it reaches a certain number, it means that this patient is really unwell. So they put out what's known as a medical emergency team call on all the pages or the bleeps, and everybody goes to the patient. So if there's a deteriorating patient, you will know, and everybody will do something about that. I don't think that the nursing capacity in South Africa can always allow for that. I don't think that, you often have one nurse having to look after 60 patients, and it's not fair on him or her, and it's not fair on the patients. But yeah, that certainly makes a big difference. And in fact, if I ever were to come back to South Africa, that's the one thing that I would bring back is this early warning score. I think it saves so many lives, certainly. The other thing is, of course, the hours. We don't work. I haven't done, 26, 28-hour shift here ever, and it's not allowed. It's illegal to do that. So there's something called the European Work Time. I can't actually remember what it stands for. Directive, the Work Time Directive, which says that you're not allowed to work a certain number of hours in 1 week, and certainly only 13 hours at any go. So it makes a very big difference as well. I think when we tell our war stories about how we worked in South Africa, even as medical students, it's wild. So those are some of the big differences that I've noticed. The patient population, the diseases are all the same. Nothing changes. The diseases are the same. Of course, we don't see as many infectious diseases here, where South Africa has got, many burdens of disease, both non-communicable and communicable diseases. We don't see a large number of opportunistic infections, and if we do, the patient will be isolated immediately, and they'll speak to a very big London hospital about this HIV case, or TB case, whereas in South Africa it's just open ward, and it's like, people go in when I go in to do a lumbar puncture, for example, in somebody who we might think might have TB, it's full PPE that you've got on. You go in like a surgical gown, masked up, everything. Whereas in South Africa, you sort of just go, "Hi, I'm here to do your LP." So it's very, very different. There are parts of it that are a bit frustrating here, if coming from South Africa, in terms of, because when you work here as what they call a senior health officer, which is equivalent to a medical officer, you're often on the junior rota, and they often assume that you don't have the competencies to do a lot of things, because if you come through the system here, often you don't have the opportunity to do lumbar punctures, put in arterial lines, that sort of thing, as a medical student. And therefore, you feel like your hands are a bit more tied. It's great for the patients. And I think that's why it also increases, that's why the training duration here is so long compared to in South Africa, because you only start doing a lot of these things when you're a more senior doctor. And then the last thing that I would say is the types of patients that they accept to critical care here is completely different. So, the benefit goes into offering the critical care space, even if it's for what's known as a trial of ITU. So it's just to see if they'll do well in 24 hours, whether this is an 88-year-old person or doesn't matter. And I think that's partly because the population here is so much older. My first week on ITU, I think I didn't see anybody under the age of 70, which is incredible. So those are some of the differences.
Would you say there's some interesting similarities between us and the UK?
Yes, I think so. I think the attitude of the doctors everywhere is similar. I think I found that quite reassuring, at least, in that everybody just really does want to do the best for their patients. And I think there are loads of difficulties that the NHS faces that we don't know of, and that it comes with the resource allocation, and it comes with its own issues. And there are some things in South Africa, again, managerial things that could be done better, that maybe there's a hindrance for whatever reason, whether it's financial or structural. But yeah, those are probably some of the main similarities.
So you spoke about now advantages and disadvantages of both systems. What was your driving decision to go to the UK?
I think it was many-fold. I think so. We came here partly because family are here. So my wife's family are all here. So that was a big driver for us. Pietermaritzburg is beautiful. It was a bit of a sleepy hollow, and we were quite far from family. So it's really nice to be closer to family. I think one of the 2021 riots that was quite close to home where we lived, and that was a big driver for us to say that we have the opportunity and we have the ability to do this. And that's a big part of it as well, was for our son, because we didn't want him to be in that environment, because it is a bit volatile. Now, I think people often ask me, do we regret leaving? And there will always be I will always be South African. That is just, I am South African, and my son will always be South African. And I regret that we felt that we had to leave. And that's the biggest thing that I regret, is that we felt that we had to leave. And I think it was after I interviewed for a neurology registrar post and I didn't get the post, I felt that was probably the big driving force. And we said we could have moved back to Johannesburg, we could have gone to Cape Town, we could have gone to Eastern Cape, wherever. And if we had just been patient, I would have probably gotten a post. But we didn't want to necessarily do that. So I think we were just in the fortunate position that we had the opportunity to do this. But it's not for everybody, you know.
Yeah.
Would you ever come back to South Africa?
That's such a difficult question. I'm not going to say no, because it's never is never the answer. So I don't know is the honest answer. I feel like if we had the opportunity to come back, and the system has changed a bit, I think yes. I think we would like to. We would like to have that opportunity. I think for the foreseeable future, while our son grows up and goes through schooling here, certainly not. But I just feel like we would be able to bring a wealth of knowledge from a system-based thing back to South Africa. And in fact, I'm still looking for somebody in South Africa who wants to implement this early warning score. So let me know if you're interested, and I can tell you all about it.
You just mentioned that if there was a change in the system, you would consider coming back. What change would that be?
So I think it would need to be a top-down change. I think one of the big things that, of course, hampers a lot of our ability as doctors to work is the resource allocation. And I think misspending of money, whether it's real or alleged or whatever the case is, makes it very, very frustrating. And I think we often feel like there's no accountability either. So I think if that changed, and if the system became more equitable, and we were able to provide the same high standard of care to everybody, regardless of whether you have got medical insurance or not, that's something that we would say, yeah, we would come. And I think the rebuttal to that would be like, well, why didn't you come and change that then? Why did you leave? And I think part of it is a personal sort of thing. And our priorities change as well. And my priority is my family. So that would be my rebuttal to that rebuttal. But certainly, I think if the system became more equitable, and there was evidently less mismanagement and spending misfortunes, I think that would push us. Yeah.
If there's like one message you would leave to the next generation of physicians, what would it be?
That's a tough question. I think perhaps the most important thing is that I think regardless of where you go to work as a physician, whether it's in South Africa, whether it's elsewhere in Africa, in the UK, in Europe, wherever it is, it's going to be difficult for different reasons. Some places you're going to be undervalued, some places you're going to be underpaid and undervalued. In some places you will find it very difficult. And, the grass isn't always greener on the other side. And I think you just need to decide which shade of brown grass you're happy with, and that your situations will change. And I think perhaps the biggest thing that I'd like to share with the next generation of physicians and next generation of doctors really is that in life, you'll always disappoint somebody, and it's your responsibility to choose who you're going to disappoint. And what I mean by that is, if I'm at work and it's 5:00 in the evening and I have the opportunity to extend my shift and do a locum for another 4 hours, that would make my work very happy. I'd say, well, there we go, we've got somebody to cover this shift. But then I would be disappointing my family at home for not being there for bedtime, etc. But by going home, I'm disappointing my work. but you have the opportunity to choose who you want to disappoint. So make sure you disappoint the right people for the right reasons.
Speaking of your family and personal life, besides obviously working in the UK, what do you do in your free time to decompress outside of medicine?
Yeah, so I absolutely love going to the parks with my son and to take a rugby ball, and I'm trying to teach him how to play rugby, and he wants to play for South Africa one day. I said, good, let's keep it that let's keep it that way. I think we enjoy using our off time to go and explore. So the houses in the UK are so much smaller than in South Africa, like little matchboxes. But we've got the benefit of having these parks and everything that we go to. So we try and go and explore at least every weekend, whether it's a new park or, we make sure to walk somewhere and get some physical activity. So we definitely enjoy that.
That's great. Wow. I think we'll close now with like a fun rapid fire of questions. Okay. So the first one is, what is your favorite medical TV show? Although I think we might know the answer already.
Yeah, I mean, it's Scrubs, right? I think Scrubs is just but the nice thing about Scrubs is that it doesn't matter when you watch it, as a student, as an intern, as an MO, whatever, it is applicable at every stage. And I actually rewatched it, I think, a year and a half ago, and it's still applicable. So yeah, that's my favorite.
Have you watched The Pits? Apparently that's really good.
No, I haven't. But I mean, that's a bit, I don't know, I feel like they've stolen that name. The surgical pit is at Barra, so can we just get that straight? Okay. That is the pit. That's not, copyright laws.
Okay, and then on a long shift, would you say you prefer coffee or tea?
Literally having a cup of coffee now. Yeah, coffee. It's awful. Yeah, coffee.
So one lesson med school didn't teach you. What would you say that is?
It didn't teach empathy, because I don't think you can teach empathy. And you could see that in some doctors who they just don't have the ability to empathize. And I wish that there was ability for medical school to teach empathy.
What do you miss most from South Africa?
Oh, a good braai in the sun, and with friends. That absolutely. I mean, we try and have a braai here as well. I refuse to call it a barbecue because that's just sacrilege. It's a braai. It will always be a braai. But yeah, I miss that, and I miss our incredible friends. Spending weekends with them. That's the big thing.
And if you had to describe internal medicine in one word, what would it be?
Yeah, no, don't put me on the spot or anything. Challenging.
Yeah.
That's good.
Yeah, I think I don't know what else. It's challenging in a good and a bad way. It challenges you personally. It challenges you academically, clinically, and it's a good time. It's a good challenge.
Yes. Well, that's all for the questions. I think we can go on to, if you have any questions for us, like want to know anything about med school or the society.
I'd like to know. So, so I mean, you guys are obviously doing a phenomenal job, and it's, I just stalk you on social media, and I'm just like, yes, look at what they're doing today. So, just thank you for doing all of those things. So, what are your plans for the next year? What do you think? What is your big thing that you would like to achieve as a society for the next year?
Yes. Well, I think the three of us are in the position where we're in fourth year now, or GEM 2. So technically our term ends on the society this year as we go into clinical years, which is really sad. I've been on the society since first year, so this is my fourth year on the society. Yeah.
That's amazing.
Literally, it's been my whole med school career.
That's so exciting.
Yes, but I think just seeing it grow from being in first year compared to where we are now in my fourth year, I think is really just such a drastic change. We started something called Curious Cases in my first year, which has now become an amazing event. We have incredible specialists come and share their most fascinating cases. We also have like extraordinary speakers. Last year we had Dr. Oliver, who shared her journey in cancer, heart failure, and like both ends of the stethoscope, which is really fascinating.
Wow.
The society is also sponsored now by Fed Health, which is amazing. We don't have to worry about expenses.
Very nice. Nice scrubs.
Nice, and then we also have built some amazing outreach partners. I'm not sure if the BHCC was a partner when you were around, but that's been a long-standing partner with the society. They do hospital and clinic outreach, so we've maintained that relationship. We've built a really good relationship with the Johannesburg Pediatric Colorectal Clinic. So every Wednesday we are helping in the clinic at Barra. Now also relationship with the Grace Factory, which helps mother and children. We started an ED program at Helen Joseph, so we do night shifts there voluntarily.
That's amazing. Wow.
So I think just continuing the trajectory that it's on now, just continual growth. We have an amazing committee, so I think we are leaving it in incredible hands. I think we'll all stay around. The society is also involved in some research as well. We had a competition that just launched, and that's now in the process of reviewing and editing with the journal. So that's really exciting. So yeah, I think just in general, just continuing the way we've been going for the last few years.
Seeing continuous growth and keeping the society moving forward, I think, is the main goal.
That's incredible.
Yeah, for the first time, I think it was last year, we actually had 100 applicants apply to join the society with such a small comp. And then we had to independently register last year, so now we on our own, technically we're not under the MSc anymore. So we have independently registered. Now we're also expanding into a subcommittee so people can volunteer. We have different outreach initiatives like soup kitchens at the Johannesburg Children's Home. So just trying to open up as many volunteer opportunities for everyone.
I mean, from our Mickey Mouse operation to this is like night and day. So this is incredible to hear. Honestly, well done.
Thank you.
Thank you, Doctor.
Yeah, we're all very proud. Even now, we launched a podcast.
I know, it's incredible. And I'm sorry that I had to be your first guest. That's terrible.
I think you're the perfect first guest.
We learned so much. Thank you, Doctor.
It's such a pleasure. Well, thank you for having me.
Thank you very much for watching our first episode of the Impressions podcast. Thank you very much to Dr. Juan Jansen van Vuuren for his incredible insights and knowledge he has shared with us. We'll see you in the next episode.